This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. Today, I'd like to provide you with an overview of pulmonary hypertension.
Let's start this part with a case. Early this year, I saw a 38-year-old female with a prior history of intravenous drug use and a known hepatitis C. She presented to my office for evaluation of 18 months of fatigue, exertional dyspnea, vague substernal chest pain, and peripheral edema. Her examination showed elevated jugular venous pressure and a wide split S2, and her EKG showed increased R wave voltage in V1 and a high amplitude 4 mm P wave in lead 2. So what's the diagnosis? Let me leave this here for a minute, let you think about it. So this patient has all of the signs and symptoms of pulmonary hypertension. She has dyspnea. She has elevated right-sided pressures as evidenced by edema and neck vein distension, and she had classic substernal chest pain that I'll get to in a minute. Given absence of other medical problems other than her hepatitis C, her pulmonary hypertension is much less likely to be a secondary cause from cardiopulmonary disease. Rather, I suspect that she had a primary problem arising in her pulmonary vascular bed. Now, in this case, I felt she likely had World Health Organization Group 1 pulmonary arterial hypertension. Group 1 are the idiopathic causes that are not secondary. They're all of the primary causes where the pulmonary hypertension arises in the pulmonary vascular bed, and specifically, she was diagnosed ultimately with something called hepatopulmonary syndrome. More about the World Health classification, and then in the next part, I'll get into some of the special syndromes that are very interesting, like hepatopulmonary syndrome. But in any case, I just wanted to give you a real live case that we can use as a backdrop as we go forward and talk about all of these classification systems. This beautiful illustration provided by Mariana Ruiz Villarreal shows a representation of a normal heart with RA, RV, and pulmonary artery indicated in blue for the deoxygenated blood, and LA, left ventricle, and aorta in red. Note that the healthy LV wall thickness over here is greater than the RV wall thickness, and that's because the LV needs to generate a mean arterial pressure in the 60 to 90 range, whereas the right ventricle only needs to generate a mean pressure in the 15 to 20 range, which is only about a quarter of the pressure, so the muscle mass is much less on the right than on the left in a healthy patient. In this illustration, we visualize just how hypertrophied the RV can become in severe pulmonary hypertension. Here's the wall thickness, and compare that to the other side. In patients with severe pulmonary hypertension, their mean pulmonary pressures can actually equal or even exceed systemic pressures. I've seen patients with pulmonary artery systolics of 105, 110, in the same patient who's shocky with a systemic systolic of only 85 to 90. In order to appreciate an echocardiogram from a patient with right heart failure, which I'll show you in a minute, let me first show you an echocardiogram from a normal patient. So this study is an apical 4-chamber view. The probe is at the top at the apex, and you can see the right atrium and RLA, RV and LV, and the two valves between the atrium and the ventricles. Let's let this run. So we see excellent contraction, symmetric, both of the ventricles, and notice that the RV is about 70% of the LV. That's a typical ratio. The LV is a larger chamber with a thicker wall. So I think you should have enjoyed just seeing how a normal heart functions, and now you'll be in a better way to a better position to appreciate the next slide, which shows RV dysfunction from severe pulmonary hypertension. In this echocardiogram of someone with advanced pulmonary hypertension and right heart failure, First, notice how markedly dilated the RV, which is over here, and the RA is. Second, notice how the septum is moving over towards the left, encroaching on the left ventricle. And also, we'll show you in a minute when I run this, that the RV hardly moves, but the LV is hypercontractile. And the reason the LV is hypercontractile is it's trying to compensate for underfilling due to right-sided poor output. And we'll also be able to see this septum bowing over towards the left when I run this. So it goes by pretty quickly. But you could see the bowing of the septum in the middle, and the LV was really collapsing with each cardiac cycle.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.